All right, good evening, everyone, and welcome to this weekend's tutorial. What have I done again? Hold on, I'm trying to just exit the screen. Okay. So this evening we'll be looking at a very practical discussion on electrocardiography, the basics, and how to read an ECG. You will all agree with me that ECG is very important, especially in critical care settings, emergencies, and in the OR. So it's important for us to look at it as anesthetist and critical care practitioners. Please, if you're joining, can you mute your mics, please? Okay, so our learning objectives or learning outcomes at the end of this tutorials, every participant should be able to understand the basics of ECG or EKG as it may be called. All right, be able to understand the indications and should be able to read, number one, to identify life-threatening ECG changes on our monitors and to also be able to action appropriate interventions. So by way of introductions, my screen is moving. Okay, so by way of introduction, the electrocardiography is a diagnostic tool that helps to record the electrical activity of the heart over a period of time. All right, it is, somebody is raising his hand. You can't hear me, John Paul, what's happening? John Paul, you are raising your hand. Any problem?
Sorry, Prof, just by mistake.
Okay, so ECG is essential in detecting arrhythmias, myocardial ischemia, infarction. It's also very useful in detecting common electrolyte imbalances, and you can also use it to detect conduction abnormalities. All right, so ECG has gone a long way, come a long way. As far as the 19th centuries, in 1842, an Italian physicist demonstrated that an electric current is generated each time the heart contracted. All right, after that, Augustus Waller, a British physiologist, was the first to record the first human electrogram using a capillary electrometer. Einthoven, that gave us the Einthoven triangle, was a Dutch physiologist who developed the first practical ECG machine and introduced the PQRST nomenclature. This work earned the Nobel Prize in 1924. And in the early 20th centuries, we have the precordial leaks. V1 to V6 has been introduced by Frank Wilson, and also the augmented limbs, all right, were introduced by Goldberger, especially in the 1950s, and which form what we know as the modern 12-lead ECG system. All right. So the basics, let's look at the basics of ECG. Okay, and okay. The heart, as we know, is an electromechanical pump, all right, generating electrical impulses, all right, which lead to muscle contractions. And these muscular contractions is what leads to ejection fraction, all right, ejection of blood from the left ventricles by each cardiac cycle. So the electrical activity of the heart follows a very systematic pathway. All right. Remember the SA node, the sinoatrial node, all right, which is the natural pacemaker of the heart, generating impulses at the rate of 60 to 100 beats per minute. The atrioventricular node, all right, this delays impulse transmission to allow atrial contraction, while the bundle of his and his bundle branches conduct impulses to both ventricles. The Purkinje fibers, as we know, help to distribute these conducted impulses to the ventricular myocardium. All right, so this is the heart, and as we can see, the SA node, all right, just at the junction. What's happening? I hope nobody is tampering with our slide today. Oh, God have mercy. Okay. All right, the SA node here at the junction of the superior. What's happening? Is somebody tampering with my slide? Okay. Okay, so the SA node here, all right, which generates, which is the natural pacemaker of the heart, all right, generates impulse from the AV nodes, all right, down to this is the left ventricle, right ventricle, and these are the Purkinje fibers that distribute these impulses to the ventricular myocardium. All right, so you can see that, okay, from the SA node to the AV node down there. So these electrical activities lead to muscular contractions. All right, so recording ECG, remember the 4Ps, all right? Especially most of the times, I decided to put this, most of the times we're not involved in recording ECG. We just read it, but practically in ICU, we've had to read ECG ourselves. So that's why I said, let me put it here in case you find yourself, trying to record an ECG for a patient. So remember the 4Ps. You want to position the patient supine with chest, ribs, and the ankles well exposed. Then you want to place your electrode properly, both the limbs and the precordial leads, that is the chest leads. After you've done that, you put on the machine and you calibrate the machine, all right, at 10 millimeters per millivolt and at a rate of 20 millimeters per second. After that, you put on the machine, you print the tracing, and with the labelings, the name of the patient, dates, and diagnosis. Okay, so it's important for us to look at the ECG leads and where they are placed. Like we mentioned in the introduction, we have the modern 12-lead ECG. And most of the times, maybe in the theater or in our different ICUs, most of the times we have the 3 to 5 lead ECG. But sometimes we need to insist on the 12 lead ECG, especially when we have patients that we need to monitor, patients with history of arrhythmias, life-threatening arrhythmias, or patients who have had cardiac surgeries and all that. So 12 lead ECG is important. That's what we're going to consider here. So ECG records electrical activity using 12 leads, which is grouped into the limb or the chest leads. The chest leads are also known as the precordial leads. So let's look at the limb leads, all right, which is usually in the frontal plane, all right, and the bipolar leads usually form the Einthoven triangle. We're going to describe it a little more as we go on. So look at lead one, and lead one, I have a mnemonym for it, rude youngest blocked, okay, especially if you're going to apply the limb leads yourself. So the root youngest block, so you put the red lead, all right, the red lead into the right arm, okay, here if you can see. All right, so the right, you have the red all right, lead. Then on the left arm, you have the yellow lead and the green on the left leg. The black is on the right leg, which usually, what's it called, the neutral. So if you look at the lead one actually connects between, all right, the right arm and the left arm, okay? Lead two is from the right arm to the left leg, okay? While lead three is from the left arm to the left leg, all right? So this is the bipolar leads, okay? Then we have the augmented unipolar leads, all right? What's happening? I hope somebody is not tampering with my presentation. I need to be careful now because this thing is just moving on its own. Okay, so the augmented right arm, all right, the AVR, we have the augmented left arm, limb, and we have the augmented left foot. All right, so this makes up the 6 leads that you have as the limb leads. Okay, and don't forget, like I said, you use the pneumonia rude young girls blocked. All right, the red lead is on the right arm, the yellow lead is attached to the left arm, the green lead is attached to the left leg, and the black attached to the right leg. Okay, now the precordia, what's going on? The precordia leads or the chest leads are actually what we know as the horizontal leads from V1 to V6. Okay, so the V1 is at the 4th intercostal space right of the sternum, like you can see. Okay, why the V2 is also at the 4th intercostal space, but this time on the left side of the sternum. All right, V4 is at the 5th intercostal space mid-clavicular line. Okay, this is the mid-clavicular line. And in between V2 and V4 is where you place the V3 lead. All right, the V5 is at the 5th intercostal space. All right, this is at the anterior axillary line, while the V6 is also at the 5th intercostal space, but this time the mid axillary line. So this is how you place your lead, your chest leads. Okay, like I said, this is your ECG machine, okay? And this is red to the right arm, yellow to the left. Oh my God, what's going on? All right, right to the right arm, left, yellow to the left arm, the green to the left arm, and black to the right arm. All right, while you place, this is the V1 on the right side, 4th intercostal space. This is V2, 4th intercostal space on the left side of the sternum. Okay, this is, oh my God. It's Mr. James there. Please let me check the security. I hope nobody is tampering with my presentation. Okay, so V5, V4 here, all right, at the 5th intercostal space, mid-clavicular line, all right, in between the V2 and the V4 is the V3, okay? V5 is at the anterior axillary line, okay, at the 5th intercostal space, while V6 is at the 5th intercostal space, the mid axillary line. This anterior axillary and the mid axillary. This is how you place your lead, all right, for you to record a 12 lead ECG. Okay, the Einthoven triangle, like I mentioned before, is an imaginary inverted equilateral triangle. All right, it's inverted, it's centered on the heart, whose sides are formed by the axis of the standard lip leads. Okay, so they're like we mentioned before. So this is lead 1, all right, connected between the right arm and the left arm. Lead 2, from right arm to the left leg, while lead 3 is from left arm to the left leg. Okay, so if you look at So if you look at the different leads, this is what you will see. And the reason why I'm showing you all this is that you will see the morphology of the ECG, all right? The PQRS is upright in lead 1, lead 2, lead 3. All right, Y is inverted in augmented foot link, AVL and AVR. So it's important for you to know the morphology of the different. Now the leads are looking at the heart from different angle, looking at the same electrical activity of the heart from different angle. So look at your lead 1, look at your lead 2, lead 3, and these are the augmented limbs, all right? This augmented foot limb, this is the augmented left limb, and this is the augmented right limb. So it shows you different morphologies of the same electrical activity of the heart being looked at different angles. Okay, and this is what we known as the congruity of leads. All right, and what does it mean? It means that the different ECG leads represent the same electrical activity of the heart, but looking at it from different angles. And it is important, critical, that you understand congruency of leads, because it helps you to determine ischemia infarction, and especially axis deviation. All right, so if you're looking at, for instance, patients that have inferior MI, you want to look at lead 2, lead 3, and AVF, all right, because they are looking at the electrical activity of the heart from the inferior surface of the heart. Okay, it makes sense if you look at it from here. So, oh my God. Okay. All right, so look at it, inferior side, lead 2, lead 3, okay? You can see, and AVF. Okay, all of these are looking at the inferior aspect of the heart, okay? Lead 2, lead 3, okay? So lateral leads, if you're looking at the lateral aspect, lateral MI, all right, you look at the lead 1, all right, augmented lead on the left, V5, V6. Septal leads look at the electrical activity of the heart from the septal surface of the heart, while the anterior leads look at the V3 and V4, all right? V3 and V4 are the anterior leads, and they look at the electrical activity, all right, from the vantage from the arterial wall of the right and left ventricles. This is important. You don't need to cram it, just look at. Guys, something is happening. I don't know what's happening to my slides. Mr. James, is somebody there? What's going on with my slide? I hope nobody is taking over this presentation. I'm not the one doing all this.
Excuse me, Prof. I think you're on a slideshow play. You are on a slideshow.
Sorry?
He said you are in slideshow. That's why it is moving up and down by itself.
Okay, yeah, because I'm surprised. I'm not doing it and it's moving. So what do I do now?
Remove the play part. You're on the slideshow play.
Oh my God. Okay.
You can exit and reshare the screen.
Oh my God. My apologies. I don't know what's okay. Well, can you see my screen?
Yes, sir. Very clear, sir.
Okay, okay. All right, so like I said, the congruity of the leads, is just describing how different leads are looking at the same electrical activity of the heart from different areas. Like I mentioned, the inferior lead, inferior aspect of the heart, you use the lead 2, lead 3, and the augmented foot leads. The lateral aspect, you look at lead 1 and AVL and all that. This will become very useful as we proceed in the course of the discussion. Okay. Now, if you're looking at the ECG, you'll see that the paper is printed at a certain rate, like we mentioned, 25 millimeters per second. All right. And if you're looking at the S-axis, you are measuring time, and the voltage of the waveforms are measured vertically on the y-axis. So the larger the waveforms you're seeing show you the greater electrical voltage of the heart. Okay, so this is a basic ECG I was talking about. So this is the S-axis, which shows you the time, and the y-axis, the voltage. Okay, we're going to see some of this as we go on. Okay, so we'll see more of this. Now let's look at the morphology of the ECG waveforms itself. Like I mentioned, it was Einthoven, all right, that gave the nomenclature PQROST that we commonly use today. So the P wave, what does the P wave represent? This is the P wave, all right? The P wave represents atrial depolarization, right from the ASA node, all right, which is the pacemaker cell of the heart, all right? Once the electrical activity gets to the atrium, all right, you see the P wave, which is a positive deflection, all right? And this is the P wave. Okay, you can see it here. And it has a normal duration, which is about, it should actually be less than 120 milliseconds, all right? And that is about 3 small pulses, as we're going to see. Oh my God. I hope I removed the slide play. All right, this is it here. Then the PR interval, this is the time from the SA node activation to ventricular depolarization. All right, it's usually longer than the P wave and is between 120 to 200 milliseconds. Okay, and then we have the QRS complex, which depicts ventricular depolarization. Okay, it's almost of the same duration with the P wave, with about less than 120 milliseconds. Okay, so the next thing is the ST segment, all right, and this ST segment is very important, okay, because ideally it should be isoelectric, it should be flat. Oh my God, what's going on? I'm so sorry, I'm getting distracted with all this up and down movement. Okay, so the ST segment, all right, it should be isoelectric. And what does it represent? It represents early ventricular repolarization. All right, the T wave itself, all right, should be upright in all leads except the augmented right limb. Okay, so it should usually be upright, and it represents full ventricular repolarization. Okay, and this is why if you're going to look at it when you're doing depolarization, what's it called, synchronization or defibrillation, you want to synchronize your electrical discharges. You don't want it on the T wave because this is during ventricular repolarization, and if you do that, then you can have ventricular arrhythmias. So the Q2 intervals represents the total ventricular depolarization and repolarization, all right? And it's usually less than 440 milliseconds in men, or less than 460 milliseconds in women. Okay, so there's what we call the ECG grid, okay, which is the standardized background on which the heart's electrical activity is recorded. The grid consists of small and large squares. All right, this helps to measure the duration, the time, and the voltage, which is the amplitude of each ECG wave and intervals. Okay? Okay, so like I mentioned, the horizontal axis represents the time, while the vertical axis represents the voltage. So each small pulse is about 1 millimeter, all right, which is about 0.04 seconds. And 5 small pulses make up a large pulse. And if you multiply 0.04 by 5, you have a 0.2 seconds, all right? This is how it is usually measured. Oh my God. Okay, we'll survive today. Okay, so the ECG paper itself, like I mentioned, the small square, all right, the calibration, we've done this, so let's go ahead. The paper speed, the standard speed is about 25 millimeters per second, all right, which is each large square, you know, and practical applications, we're going to go into that as we go on. So how do you read an ECG? This is where we are coming to the nitty-gritty of today's presentation. So when you have an ECG, I hope all of us will try, if we have ECG machine in our units, try tomorrow or Monday to try to see if you can record an ECG of a patient, all right, a 12-lead ECG. But if the ECG has been recorded, how do you read it? Okay, so the first thing you're going to do is to understand the step-by-step way to read it. So the first thing is to confirm the patient's details, okay? Ensure the correct name, the date, and the time of recording, and this is important. Also, you want to verify the standard setting is the paper speed and the amplitude correct. That is the paper speed at 25 millimeters per second, while the amplitude is about 10 millimeters per millivolts. Okay, so that's the first thing you want to do. Then I have a mnemonics, which has helped me to look at how to read the ECG. So after you have confirmed the ECG details, I usually tell my student, raise the ECG. RAISE, all right, raise the ECG. The first thing is you want to look at the rhythm. Look at the rhythm, because the rhythm will determine the rate, how you calculate the rate. So how do you know a normal rhythm? Every P wave is followed by a QROST wave, all right? That's the first way to know that this rhythm is normal. Every P wave, all right, is followed by a QROST complex. Number two, you want to look at the RR intervals, all right? They should be regular. The RR intervals should be regular. So after you have looked at the rhythm and you have confirmed a regular or a sinus rhythm, you want to look at the rates, all right? What is the heart rate? Okay, so you divide 300 by the number of large square waves between two arrow waves. Okay, after I leave here and I will show you how to do that. 300 divided by the number of large square waves between two arrow waves. Or if you are going to use the small squares, you divide 1,500 by the number of small squares between two arrow waves. Okay, but if the rhythm is irregular, what you need to do is to count the number of QRS complex on a strip and multiply it by 6. Okay, so that is how to determine the rate, the heart rate, all right, of the patient from your ECG. So you want to look at the axis, okay? You want to look at the axis of the heart. And when we're looking at the axis of the heart, usually we use lead 1 and the augmented foot limb. Okay, lead 1 and the augmented foot lead. Okay, so if lead 1 is positive and the AVF is positive, it shows you a normal axis. That is, the lead 1 is positive and AVF is positive, it shows you a normal axis. Then if lead 1 is positive, while the AVF is negative, this shows you a left axis deviation. Lead 1 positive, AVF negative. So that is left axis deviation. All right, right axis deviation is when lead 1 is negative and AVF is positive. Okay, and when you have both leads negative, you have what we know as the extreme axis deviation. All right, this is what we call the no man's land. Okay, so you look at the lead 1 and lead AVF to determine the axis. So the second thing you're going to look at is the intervals. Okay, and we're looking at 3 different intervals. Okay, you want to look at the PR interval. It should be between 0.12, all right, 120 milliseconds to 200 milliseconds. Okay. Then you have the QRS interval, which should be less or equal to 0.12 seconds. Then the QTI intervals, like we mentioned before, okay? You look at the intervals and determine that they are normal or abnormal. Then S, you look at the segments, the different segments. And what we're looking at is the ST segment. Is the ST elevated, ST segment elevated, like you will see in STEMI, myocardial infarction, or is the ST segment depressed, as you will see in myocardial ischemia? And the last thing you're going to talk about, look at in reading the ECG, is the E. You want to look at the enlargement of the chambers, all right? In right atrial enlargement, you'll see the P wave is greater than 3 small squares in lead 2. You look at lead 2. Don't forget, lead 2 look at the heart from the right arm to the left foot. So when you look at lead 2 and the P wave is greater than 3 small squares, all right, that shows you a right atrial enlargement. Left atrial enlargement, the P wave will be greater than 1 square in V1, lead V1, okay? Left ventricular hypertrophy, which is very important, especially in chronic hypertensives, all right? You'll see there'll be a tall arrow waves in the chest leads, okay? The V5, V6, okay? Which is looking at the anterior parts of the heart, all right? So the arrows will be very tall, all right? And there's a calculation, we're going to come into that as we go on. So at V5, V6, right ventricular hypertrophy is when you see the RS ratio should be greater than 1, okay? That is, the R wave is larger than the S wave in V1 and V2. So when you're reading the ECG, I always tell people, raise the ECG systematically. Look at R, the reading and the rate. Look at the axis. Is it a normal axis? Is it right axis deviation or left axis deviation or extreme axis deviation? Then you look at the intervals. You look at the ST segment and you look at the enlargement of the chambers. Okay, let's look at this now. Okay, so the first thing is want to determine the heart rate. Like I mentioned, the heart rate depends on whether the reading is regular or irregular. Okay, so you've looked at the RR intervals, the space between the RR, they are regular. Okay, they must be regular. So if they are regular, it shows that the rhythm is sinus. So you calculate or you count the number of last squares. Okay, I don't know if you can see what I'm doing here. How many last squares can you see from 3, okay? You can see 1, 2, 3 last squares. So you divide 300 by 3, the heart rate of this patient is about 100 beats per minute. I hope you can see it, okay? But if you look at this now, you can't. Okay.
Holy Ghost, though.
Okay, so look at the space between the 2 R waves. Look at this one, 1, 2, 3, 4, 5. So you divide 300 by 5, so the heart rate is 60. But look at this tachycardic patient, all right? The RR wave has only 1 square. So you divide 300 by 1, you have 300 beats per minute as the heart rate, okay? I hope that is clear. For the irregular reading, what you need to do is count the number of QRS complexes, okay, in one strip, okay, and you multiply this by 10, excuse me. So look at this now. In a strip, okay, you have 1, 2, 3, 4, 5, 6, 7, 8. All right, this is 8, okay? And you multiply this 8 by 10. It gives you a heartbeat of 80 beats per minute. All right, I hope that is clear. So the second thing we're going to do, all right, if you read in regular, I mentioned this before, look at it. Oh my God, I hope. Okay, look at it now. Is this a normal reading? Anybody? Look at the RR intervals. Are they regular? Anybody?
No.
No,
So this is an irregular rhythm, isn't it?
irregular, yeah.
Yes. Another thing, look at the PQRS complex. The PQRS, you know, the P wave is always followed by QRS. Okay, but here we're this thing is moving again. Where am I? Okay, so look at it. All right, now is the P wave always followed by QRS? Oh my God. Maybe I should not just touch. Okay, so the sinus reading, all right, normal P wave before QRS complex, but in atrial arrhythmias, either fibrillation or flutter, you'll see that the P wave is absent. We're going to look at that. Okay, but the important thing is you want to look at the regularity, and you look at the arrow interval, they are not regular. So these are the irregular rhythm. Okay. Now look at the P wave. We're going to look at the analysis of the P wave. The first thing is there a P wave at all in this ECG? Absent P wave is an atrial abnormality, atrial fibrillation, whatever it is. If it's present, look at the shape. Okay, if it's upright in lead 2, don't forget lead 2, look at the heart from the right arm to the left leg. So if it's upright in lead 2, it shows it's normal. But if it's abnormal, all right, maybe it's peaked, you can see, or maybe it's larger than 3 square waves, it shows right atrial enlargement. Okay, and like I said, is the P wave always before every QRS complex. So if you look at this, there's what we call P pulmonale, okay? It's greater than 3 small squares. So this is P pulmonale, right atrial enlargement, all right? P mitralline, all right? This is peaked, all right? There are 2 P wave. This is the P wave, but it's peaked, all right? We have almost like 2 waves in one, all right? So you look at the presence of a P wave, then you look at the shape and the direction of the P wave for you to know if there's any atrial abnormality. Okay, so look at it like this is just a table to show you what I've been talking about. So don't forget your P wave usually represents atrial depolarization and is best assessed in lead 2 or V1 if it's biphasic. All right. Changes in your P wave morphology, like I mentioned, can indicate either atrial enlargement or conduction abnormality. So right atrial abnormality is known as the P pulmonale. You have a tall peaked P waves in lead 2 and V1. Okay, so the P wave is greater than 3 small squares, and the causes can be pulmonary hypertension, pulmonary embolism, and these are some common things we see in our ICUs. All right, if the P wave is wide and notched, all right, and there is especially in lead 2 and biphasic in lead V1, all right, is P mitrale, which is left atrial enlargement. After P waves, we talked about this. And if the P wave is inverted, especially in lead 2, you have a junctional rhythm in your hand. But if you have sawtooth wave P waves, you have flutter waves. I remember during our part 1 in Ibadan, you know, they showed us this atrial flutter, and many of us failed it. But I remember a friend of mine just came out smiling and said, I saw atrial flutter, and that gave it away. So when you saw the sawtooth P waves, because I know that you can be given ECG tracings, all right, to interpret, and that's why we're doing this tutorial today. All right, so atrial fibrillation. My God, time is going fast. And we're in atrial fibrillation, you see that it's irregularly irregular. Okay, look at no distinct P waves. Okay. Can you see any P waves here? Anybody, can you see a distinct P waves here? Anybody?
No, sir.
So there's no P wave here, isn't it? Okay. Okay, somebody can see a P wave? I don't want to touch again. I think my touching it is moving up and down. So number 2, look at the RR interval, okay? They are not regular, isn't it? The RR interval is not regular, so it's irregular, all right? And we have variable ventricular response. So when you are given this ECG tracing, your spot diagnosis is that this is an atrial fibrillation. And if you meet somebody like me and you get the interpretation well, I will go ahead to ask you what are the common causes of this ECG finding, okay? And my mnemonic is times, okay? Times cause atrial fibrillation. Times cause atrial fibrillation. So your thyroidism, infection, mitral valve diseases, all right, electrolyte abnormalities, and surgery. These are the common causes of atrial fibrillation. Okay. Then we'll look at now look at the sawtooth appearance here. Okay. So what are the things you look at it? If you're trying to look at it, okay, the RR interval looks regular, isn't it? Can we see that? 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So the RR intervals are equally spaced. Am I correct? Can you see that?
Yes,
okay.
Prof.
Okay. And then to look at if it's regular now, yes, let's count the number of big squares between the RR interval. Oh my God. Okay, look at, okay, look at it. This is 1, 2, 3, isn't it? B square, 1, 2, 3, 4. Is this almost 4? 4, isn't it? So you divide 300 by 4. What will that give you? That will be your heart rate, okay? So this is a sawtooth, and look at the P waves here. Okay, very irregular. So, but the RR interval are regular. So this is an atrial flutter. Okay, and the common causes are atrial dilatation, like your mitral valve disease, post-cardiac surgery, and hyperthyroidism. Actually, atrial flutter and atrial fibrillation can be caused by the same conditions. Okay, so look at it so that you won't forget. You see atrial fibrillation, atrial flutter, and sometimes you may be given a multifocal atrial tachycardia. All right. So let's look at the right atrial enlargement. I don't think we can finish this lecture today. Let me just take my time. We can reschedule tomorrow. Now look at the P wave here. Okay, like we said, the P wave should be less than 3 small square, isn't it? So this is the P wave, and look at the small squares in between, all right? This is more than 3 squares, okay? 3 small squares. Don't forget that 5 small squares make 1 large square, okay? So, and this is usually in lead 2 and V1. So you see P pulmonale here. Tall peaked P waves refers to right atrial enlargement. Like I mentioned, common causes are pulmonary hypertension, pulmonary embolism. All right, COPD patients, tetralogy of Fallot usually see a tall peaked P waves. All right, so the left atrial enlargement, P mitral valve, or P mitrale, so to say, you see the notched P waves that is wide. All right, look at the P wave here. This is the P wave on lead 2. You see that it's notched, all right, and it's also wide, okay? And the common causes are mitral stenosis, that's what it's called, P mitrale. Oh my God. Where am I? Okay. Oh my God. That's happened again, guys. Can you see my slide? Can you still see my slide?
Yes, sir.
Prof.
Yes,
Yes,
sir.
We
Yes,
can
sir.
see your slides. But when
Okay.
P mitrale.
Okay. So the common cause is mitral. It's not moving now. Okay, so this is here, P mitrale. Okay, mitral stenosis. You'll see the notched wide P waves. Okay, so the intervals, like I said, you raise your ECG, you look at the rate, then we look at the intervals, and let's look at the intervals, okay? The PR interval is usually the time taken for an impulse to move from the SA node to the AV node, all right? Usually in between 3 to 5 small squares, that's 120, all right, 1.2 seconds or 120 milliseconds, okay? We can have prolonged PR interval when it is more than 5 small squares, all right? And this is when you have your 1st degree heart block, okay? And this may progress to 3rd degree or 2nd or 3rd degree. Common causes are electrolyte imbalance, beta blockers, and all that. When the PR interval is less than 120 milliseconds or 1.2 seconds, you can have the conditions where you have pre-excitation syndromes, like your Wolff-Parkinson-White syndrome. And most of the time, the Wolff-Parkinson-White syndrome will come with a delta wave, okay? It shows that there's an ancestral pathways. The electrical impulse generation is not just from the SA node, and that's why you have a short PR interval. I don't know if you can see the slides I tried to put here, but just to know that if you're looking at the PR interval, count the number of squares. Okay, if it's more than 5, okay, it shows that there is either one form of heart block, 1st degree, 2nd degree, and obviously you know how to do heart block. Second degree becomes prolonged. At third degree, there's usually a missed P wave that is not conducted, all right? And sometimes this can respond to your atropine or may require temporary pacing, okay? So we look at the QRS complex, all right? The normal one usually less than 120, okay, less than 3 small squares, all right? So we have three different types of, rather two different types of QRS waves. We have the narrow one, okay, where the origin is usually supraventricular in origin. For instance, when you have your supraventricular tachycardia, we had a patient like that who was a 65-year-old man who had SVT, okay, and it was a narrow complex, okay, and we had to cardiovert because the patient was becoming hypotensive, and there was immediate restoration of normal rhythm. Then when you have the QRS complex that is very wide, more than 120 milliseconds, usually due to the origin is usually the arrhythmia, the origin is usually ventricular or a bundle branch block. Sometimes you can have a pathological Q waves, all right, which is more than one small square, all right, or is greater than 25% of the QRS height. If you look at the QRS, I don't want to touch so that it doesn't move, but I hope you appreciate what I'm talking about here. So when the QRS, the width of the QRS complex is more than 3 small square, is a wide complex, and it means that the arrhythmias is coming from within the ventricles itself. But if it's less than 3 small squares, is a narrow complex ventricular arrhythmias. And examples are the SVTs, like I mentioned before. Okay, wide complexes are the ventricular tachycardia, ventricular fibrillation, and what have you. When you see a Q wave that is greater than one small square, or is more than 25% of the QRS height itself, it shows an old infarct, which is a pathological Q wave. All right, so left ventricular hypertrophy, you're looking at enlargement of the chambers now. Like I mentioned before, all right, you can use this Colon criteria, okay? And this is important, but you're going to look at the ECG tracing from V5, V6, all right? Or the augmented limb, lead, okay? So look at the S wave. When the S wave in V1 plus arrow wave in V5 or V6, all right, is more than 7 square, large square. Let me repeat that. Look at the S wave, okay, and you add it to the arrow wave, and it is more than 7 large square. It is diagnostic of left ventricular hypertrophy. Or you can look at the arrow wave itself, all right, and especially in the augmented left limb, okay, augmented leg limb, lead, sorry, and it's more than 2 large square is a diagnostic of left ventricular hypertrophy. And like we said, common causes are hypertension, all right, chronic hypertensive stage, aortic stenosis, and hypertrophic cardiomyopathy. So we use this Colon criteria to make a diagnosis of LVH. The ROVH, right ventricular hypertrophy, all right, you look at the arrow wave. The arrow wave will be very tall in V1, that is more than 7 milliliter, all right? And sometimes you can see right axis deviation. Don't forget what we talked about, right axis deviation. Lead 2 will be negative, while the AVF will be positive, all right? That shows you right axis deviation, okay? Okay, the left bundle branch block of QRS complex, like we said before, is wide, okay, more than 5 squares, small squares, and there's usually a W pattern in lead V1 with a deep S wave, okay? And these are things that you will look at as we go on. Okay, right bundle branch, but because of time. Let's look at this life-threatening white QRS complexes, the ventricular tachycardia and the ventricular fibrillation, because these are some of the things you will come across more regularly. All right, most of the bundle branch block, axis deviation, chamber enlargements, your cardiologist can help. You can still have time, but recognizing atrial fibrillation, SVT, atrial flutter, ventricular tachycardia, and ventricular fibrillation are very crucial in the critical care settings. So look at the VT. This is a VT. Look at the QRS. All right, it's very wide. All right, and there's no association between the P waves and the QRS complex. You can't see a P wave here, but the QRS complex are very wide, more than 5 squares, large squares, okay? The height, okay? The common causes here, all right? In fact, here, you will see that in lead 2 will be negative, okay? There'll be a negative deflection on lead 2. There'll be a negative deflection on the AVF, all right? This is what known as the no man's land, ventricular tachycardia. And the good thing about it is that it shows a shockable reading. So when you see a ventricular tachycardia, you can shock the patient and revert the patient to a sinus reading. Okay. Now, the Wolff-Parkinson-White is also a white QRS complex arrhythmia, but the important thing is that there's a presence of a delta wave, all right? So the delta wave, instead of having a sharp upstroke, okay, of your QRS complex, the upstroke is a little slow. That is diminished, all right? That is what we know as the delta wave, okay? And when you have this delta wave, it's either there's an electrolyte imbalance, or most of the time it could be a congenital accessory pathway, all right? So this is WPW syndrome. Now, once you are able to see a slowed QRS, you know, this is the Q, all right? It's trying to climb up, but it's slowed. It's not as sharp. Look at this other side. Okay, let me try and put my, all right? This is it here. It's not as sharp if you look at the descending limb of the QRS complex. This one is slow. There's a slow uprise, okay? And this is a delta wave. This will show you Wolff-Parkinson-White syndrome. All right. So another thing that is very important is you should be able to recognize and diagnose MI. All right. So now, normally, like we mentioned, the ST segment is usually isoelectric, it's flat. Okay. And the way the T waves are upright, all right, the T wave is upright. But when you have depression, okay, of the ST segment, all right, it usually shows some endocardial ischemia or your non-stemming or stable angina, okay? But when the ST segment, instead of, oh my God, okay, let me go here, okay? When you see, this is ST depression, okay? When you see ST elevation, this is ST elevation, okay? It's usually more than one square, one small square, okay? In 2 contiguous leads, maybe your lead 2 or V5, all right? You'll see that this is myocardial infarction, all right? ST depression when it's below the isoelectric line, all right? And in 2 leads, it's called ischemia. When you have T-wave inversion, okay, myocardial ischemia or pericarditis could be the cause. But it's important for you, to be able to recognize MI because, diagnosis to put in a needle can save this patient. Okay, J point, okay, now let's go into that. Okay, I've mentioned ST elevation, okay. So pathology, I've talked about this before, the Q waves, okay. Now the QT interval, time is fast spent. It's almost an hour now. The QT interval is prolonged in Torsades de Pontis, all right? And don't forget what Torsades de Pontis means when you have a twisting okay, of the waves along the isoelectric line. And some of the causes are electrolyte imbalance, hypokalemia, hypomagnesemia, or some drugs. Cardiac acid deviation. I think we should stop here because I still have a lot to look at. Cardiac acid deviation. We're going to look at electrolyte imbalances and the ECG. We can finish. We're already past the hour mark. And we have drug toxicity. I think we should stop here and continue next week. I think, do we agree with that? I think we should stop here. Okay.
Thank you very much, Prof.
Thank you, Prof. Yes, sir.
Any
Can stop here,
questions?
sir.
Let me stop recording so that we can take some questions or comments.